Thank you, Gene. I really appreciate those kind words. Let me try and share and make sure that's going well.
Yep, we can see it great.
Excellent. So, as Dr. Frenzone just said, sometime in the last year, I transitioned from Nemours over to drug development, specifically trying to work on problems associated with skeletal dysplasias, but I still do maintain some clinics at Nemours and certainly friendship with all my colleagues there. So I do work at Tyra. Pretty much everything that I'm going to discuss today um, is published in this paper. This QR code should take you right to that paper if you'd like to see it, and use it as a reference in your clinic going forward. I will point out the group of people that put this together is a group of neonatologists, orthopedists, and Dr. Carroll, who has really taken over for me as the lead physician in caring for these infants with severe OI in the perinatal and postnatal periods. And I would say to you, if you have ongoing questions and need some counsel, she's definitely the one to reach out to at this point. So the story for me really began with this child's mother approaching me right after having about a 20-week ultrasound in which he was identified to have osteogenesis imperfecta and was told by the maternal fetal medicine care providers that he had a lethal form of OI, that survival was not possible. And I don't really know how, but somehow his mom found me. They live relatively close by. Perhaps she looked up pediatric care in OI, and she found me, and she essentially said to me, "You need to help me figure out a way to keep my son alive." And I thought to myself, "Wow, no pressure. That's easy enough, right?" But what she didn't know was that at the same time that this phone call was happening about 12 years ago, I myself had a child in the NICU. And here you can see me with my son. He was born 26 weeks. You can literally see how he fits into the palm of my hand. You also might notice there's no gray and I had a full head of hair. But I understood now, as a person whose entire career consisted of walking into the NICU several times a week, I understood the NICU as a care provider. I understood the NICU as a consultant, and I got to understand the NICU as a parent. And I really began to think long and hard about what kinds of strategies that we could employ to try and give this child the benefit of the doubt, and what could we give to him in terms of care that might aid his survival. And I'm happy to tell you that he is in fact coming up on 12 and living a good life. Most of these phone calls start right after the 18 to 20 week ultrasound, because this is the age that the first anatomy scans are done. Much of this information is pulled from this reference. And it speaks to the fact that in, mild types of OI, essentially long bone fractures or bowing are rare. Doesn't say they never happen, but they're rare. Whereas more moderate OI, you begin to see bowing, you begin to see long bone fractures, especially towards the end of the pregnancy, which of course is not at this 18 to 20 week time frame. More severe OI, the bones become shorter in their length. Fractures and bowing are seen. There are abnormalities in the rib cage, as well as decreased mineralization throughout, especially in the skull. And then in the most severe of OI, these features are all present, but the fractures seem to be more severe. And much like we see in the clinic, if we were looking at, say, a 7-year-old with OI, it can be sometimes a little difficult to distinguish with very good precision amongst the different types. And there's this continuum. And that really should be reflected in our thinking when we look at these ultrasounds. So here's some examples of images. Here we can see some chest cages, chest walls. Looks like there may be some deformity here, probably some fractures, but not to the extent that we see almost this beading on the image on the right side of the screen. We can see clearly fractures and deformity in the long bones. And these can certainly give the trained observer a good idea of the differential diagnosis, if not of the specific diagnosis. And then we can try and be a little bit more quantitative in that there are ratios that we can look at to try and help predict survivability. One of those ratios is the chest to abdomen ratio. So that is, what is the abdominal circumference and the chest circumference? And when we see that the chest is 60% or less of the size of the abdomen, that's a bad prognostic sign. Well, it just so happens that these two images on the left side of the screen are in fact the images of the child that I showed you in the beginning. And his ratio was 0.86 with a normal ratio of about 0.9. So when we saw these images, we thought, oh, well, that doesn't look so bad. We don't see the beads on the string. The ratio looks pretty good. Okay. Well, one of the other ratios they look at is a abdominal circumference to femur ratio. So here's his femur. And what the measurer did was, as they were trained, was you draw a line from the proximal to the distal femur, and you take that as the length. Well, clearly we can recognize that that doesn't represent the true length of the bone. That represents the deformity of the fracture. And the length of the bone should have been measured by measuring the segments and adding them together, which would have completely changed the ratio. So this child was deemed to have a lethal form of OI because of essentially a miscalculation. Some of the other things that we see can be under mineralization of the calvarium. And what my MFM colleagues have taught me is it's not so much what you see in the calvarium as what you see in the brain. When the calvarium is under mineralized, the structures in the brain become very crisp and very clear, and you can see detail that you usually cannot see. And when that detail is present, you know that there's under mineralization. And of course, all of these lead to a differential, which could include osteogenesis imperfecta, as well as hypophosphatasia. And one of the main differentiators here is that OI tend to have normal appearing phalanges and hands, whereas children with hypophosphatasia, severe hypophosphatasia, have poor mineralization of the phalanges. And this is an image that was shared with me by a good friend, Dr. Deb Krakow, that illustrates the relatively normal hands in this child with OI. Another differential would include cleidocranial, especially if the features were limited to intermembranous bone. So what happens next? Well, what we hope happens next is The family will undoubtedly go to Dr. Google. We hope they finally land on the Osteogenesis Imperfecta website and then further navigate to the new diagnosis tab, where there's really a lovely group of tools that are waiting for them. There's a book that exists, I think, digitally in PDF, as well as hard copies, called Navigating a New Diagnosis, in which families that are exactly in this frame of reference can then utilize to try and plot their way forward. And that includes this, which is building your prenatal care team. And who do you need on your team if you're a parent? And, you know, you may be fortunate enough to live close by to an OI center where this team is already formed and practicing, or perhaps in more rural or disparate settings, the families need to put this together by themselves, including and not limited to genetics, obstetrics, genetic counseling, palliative care, neonatology, etc. And we want this team to be able to sit down with the family and to be able to review osteogenesis imperfecta. What does that mean? What is the natural history? What do we expect for somebody's life with osteogenesis imperfecta to look like? Let's look with the family at the ultrasound images. Let's look at these ratios together. We can talk about whether or not we should do molecular confirmation, or that can wait till after birth. We usually discuss that the genetic test itself, while certainly will confirm OI and confirm a different type, it's really unlikely to give us the kind of information that we need to predict what's going to happen, especially in the first couple of weeks and months. And we discuss treatment, long-term, short-term, and what are the goals of care? Can you see yourself as a parent taking care of a child that has a tracheostomy and needs a ventilator? Not every family is up for that type of challenge, and that's okay. Some of these more severely affected children are going to need intense respiratory support for a good period of time. And these things all have to be discussed in this meeting, which can often take a couple of hours. And of course, at the end of the meeting, after all that discussion, we come back to, well, is it lethal? And, you know, at an OI Foundation talk, I often think back to my days as a younger, almost trainee, when Horatio Plotkin would stand up and say, well, what is OI anyway? Can somebody give me a definition? And I think that's kind of important in this setting, and that is, what is lethal? What does that even mean? Well, it really does depend who you ask. And like I've already mentioned, Dr. Krakow, we've had extensive conversations about this. But for people in her field, maternal fetal medicine and OB, what that means to them is without heroic efforts. So in other words, if you choose to do sort of nothing, general resuscitation, is the baby going to live or not? Well, many babies with challenges require heroic methods, and that could even just be a simple cleft palate could require heroic efforts. So lethality gets tossed around a lot in OB MFM world, where it doesn't necessarily have the same meaning for NICU teams or for parents or pediatricians. And it's really impossible to predict. What could a delivery room scenario look like? It could look like intubation and full resuscitation. It could be CPR. It could mean comfort care. And I think from our perspective, the most important thing is that we should not impose unilaterally comfort care nor the most aggressive treatment on a family. Whatever the treatment needs to be, it needs to be based on trust, on common conversations, and on a mutually agreed upon path. So as I was thinking about all of this, I decided that it would be best to think about what was going to happen to our patients in a period of stages. And stage 0, which I essentially just talked through, was up until birth, up until delivery. Stage 1 begins at delivery and ends at about 2 weeks. Why? Because 2 weeks is going to be about the time that if a child sustained new fractures at the time of delivery, we were going to see callus, we were going to see stabilization. And much like you would have a child who could be 3 or 4 years old and have a big femur fracture, and you know the next 2 weeks are going to be particularly rough for that child because of the femur fracture. At the period of delivery, we're dealing with the femur fracture, we're dealing with the transition, and we're dealing with so many things. And excuse me, stage 1 is really the most medically complicated period. At the end of that 2 weeks, we sort of want to look up and take assessment. Where are we? What kind of respiratory support does the child need? What kind of pain relief does the child need? What kind of fracture support does the child need? And begin to start gradually making the transition to outpatient care. And then at stage 3, we get that child to the outpatient setting. So stage 1, this 1 to 2 week period, again, birth is highly traumatic. We expect fractures. And then we need to worry about airway, breathing, circulation. Those fractures could be rib fractures. And we need to deal with pain management. These babies are in significant pain when they have fractures and are coming into this really, frankly, cold, cruel world. And this is the unknown, is this combination of the transition, the fracture pain, and the chest wall compliance. So chest wall compliance, even if we don't have a chest wall that has fractures, we are going to have a chest wall that has increased compliance. And that may make it difficulty for a child to use their diaphragm to take a good tidal volume. And these are the kinds of supports that we may need to create. Our experience has been that this whole birth transition can be very complicated, but when the child is premature, this is even a more complicated situation. We think primarily because the 3rd trimester is when much of the calcium is added to the skeleton, and that cannot take place ex utero. We also know work from the BBC that really C-section and vaginal delivery are probably fracture neutral. So the decision on which is the best method of delivery really should be left to the MFM, to the OB, to the NICU team when it comes to best care for mom and baby. We are not going to change the fractures, but if we have a very undermineralized skull, perhaps it's best not to have that skull transition through the cervix. Preparation for delivery. We want to be as prepared as we can. Obviously, most tertiary care centers have very experienced NICU teams to handle complex babies, but we need to think about some extra things ahead of time. We probably want to do our resuscitation on an egg crate mattress. We want to spread out the force distribution across as wide as area as possible. We may want some extra blankets, some extra chucks, um, pre-rolled for potential intubation. We want to, if we're going to intubate, do we want to use a fiber optic scope? All of these things should be thought of and be available at the time of delivery. Who's going to take the baby from the mother to the table? All of this choreography needs to be discussed. And we know that there are resuscitation plans and, you know, um, life support plans, but we want to wonder if there are things that we could or should do to factor OI into our decision making. For example, if the child does seem to need positive pressure ventilation or intubation, we want to be careful about how we're handling the head and neck. If we're really in trouble and the heart rate is going down, do we want to consider using epi prior to chest compressions? Obviously, these are things that are, you know, very in the moment, but if you want to think about them ahead of time with the care plan team. I typically have not gone into the delivery room, and I've sort of left that to domain to those experts. I tend to be waiting in the NICU for the arrival of that child. And we want to take a careful look at the baby. This is often what we see, a child that's coming out that has significant limb deformities. And it's very easy to have your eyes move to this child's legs and hips. But the reality is the legs and hips are not important at this stage. What I would say what we really want to focus on is the chest wall, is what does that movement look like? Sometimes you can, by close observation, tell exactly where the rib fractures are. Sometimes it's very nice symmetrical movement, but the chest wall is going to give us a significant amount of information about what we need going forward. We tend to avoid blood pressures unless the child seems hemodynamically stable. And we want to look around and see what limbs the child is moving, because that gives us an idea also about what may have fractured. Immediately, in order to dose our kids, we need the weight. So really what we want to do is know the weight of our egg crate. We want to have the scale, bed scale already tailored so that when that child is set down, we instantly know and we don't have to do double movements. We know we're going to need lines, so let's just get set up to put the umbilical artery and vein catheters in. And we tend not to do a skeletal survey. Certainly, babygram is good enough, and really, honestly, probably all you need at this moment for certain is really a chest X-ray. And we're going to titrate respiratory support to try and get good blood gases and decrease chest wall movement. Well, I should say decrease extra movement. So here's an example of the babygram from the first couple of minutes. Because of the chest wall compliance, most of the time, the support that these children need is really related to PEEP. And this is a modality that is relatively new to the ICUs, relatively new, 10, 15 years new. Certainly, when I was a resident, we did not have these kinds of tools. I learned about them as a father. You can deliver PEEP now many different ways, with masks, with nasal prongs, through the mouth. But essentially what you're doing is simply stenting the airway open and allowing then for the body to do the tidal dynamics of the movement of the diaphragm. And the PEEP helps to keep the chest wall, which is overly compliant from the OI, from overly flexing and absorbing the energy that the diaphragm is trying to put forward for volume exchange. So PEEP is almost universal. And pain management. So we're going to look at the heart rate. We're going to look at the grimacing. We're going to look at what the baby does when you touch them. But almost all of these children in the first couple of days of life are going to require continuous morphine infusions, usually titrated to try and give us an effect. And then we have some breakthrough dosing if needed. We want to have the breathing be as comfortable as possible, because if there are rib fractures, every single breath is going to cause splinting and increased pain. Something else that we really imported from prenatal preemie care was care clustering. When neonatologists take care of micro preemies, they tend to leave them alone. They will every 8 hours go in and change the diaper and take the vital signs and do the hands-on care, and then they'll walk away. And even though these babies are term, often, we thought that would be an excellent choice to minimize handling and to try and get them to feel more comfortable and heal. Of course, we have our fragile bones, placards put up all over so everybody recognizes this. Another thing that's very important is weight gain. In the NICU, standard weight gain for a term infant is going to be somewhere between 20 and 30 grams a day. Excuse me. And 20 or 30 grams a day for a child who is of decreased size because of their OI is really inappropriate. And in fact, it's going to make the situation worse. It's going to make it worse because we're going to have abdominal competition. We're going to fill a belly with food. It's going to make it more difficult for the diaphragm to pull down. It could lead to reflux and even aspiration. So we try to follow the baby's lead, but the rule of thumb is 5 to 10 grams a day for the most severe kids. Having said that, we want to make sure that what we're giving the child has the appropriate micronutrients that the child needs to heal those fractures and grow appropriately. So that includes our bone mineral as well as vitamin D. We want to minimize any calcium wasting diuretics, as well as this abdominal competition. If we did not have a a molecular diagnosis from an amniocentesis or some other type of prenatal testing, now is the time where we want to pull that off and get it. It's not critical that we know. I think if a child is severely affected and has multiple fractures across their extremities, we're certainly thinking that it's going to be OI, and certainly thinking that they're going to respond to some type of bisphosphonate. However, we know that hypophosphatasia, bisphosphonates are contraindicated. So we certainly want to be able to rule that out, and that can be done pretty quickly. And even now, with the pace of molecular genetic testing, the OI diagnosis can be made in a very quick turnaround time. We do like to give our children pomidronate. We try to give the children their first cycle as early as possible, balanced with the clinical status. So we know there are case reports, and we have seen children develop some respiratory distress after their first dose. So if somebody is respiratorily unstable, I believe it's inappropriate to give them bisphosphonate. But if they're feeding on a full diet, that is, their calcium intake is sufficient, they're stable respiratorily, regardless of the support, but they're stable, that we often try and use the last 3 days of our line. So the UVC has to be taken out at day 10. So we try and give our first cycle on day 8, 9, and 10, and then pull the line. And this dose, it's a small dose, it's a lower dose that we use. It is not, obviously, it's going to have a long-term effect on bone density. But really, this is a medicine that we think helps with chronic bone pain. By the time we're starting to get out to this 10-day, 2-week period, we definitely want to start thinking about weaning our child off of morphine. And this is often a good dose of medicine to start that transition. So we use the typical Montreal dose with the day 1 and 2 and 3 lessened. And then based on the clinical status of the child, we'll give the first full dose somewhere between 4 and 8 weeks later. So we talked a little bit about this leg as we saw. This leg fell on its own. You can see here with just a little foam cube that the PT kept enlarging and putting down, and it came down. No need for casts or splints or anything like that. A lot of these positional deformities will just simply resolve with a little bit of patience. But a big part of this situation in the NICU is handling for the parents. So you can imagine going from 20 weeks to, let's just say, 40 weeks with a child where you didn't know if that child was going to live or die or not. And now here you are, and you desperately want to put that child to your chest and hold that child. Well, this, depending upon the situation, this can be something that, broadly speaking, we encourage, but we need to be pragmatic about the way we accomplish it. And if that child did have significant extremity or rib cage injuries during birth, we'll try and do that type of handling more on an egg crate or on a pillow to try and prevent additional fractures. But once we get out to that 2-week period, we are definitely encouraging the children to be held without any type of support, albeit it may take several people, nurses, OT-PTs, et cetera, to get the baby transitioned from the bed to the parent. And undoubtedly, new fractures are going to occur along the way. This is usually where we bring our orthopedic colleagues into play for their skills in wrapping our little extremities here. If we see some pain, decreased movement of an extremity, changes in vital signs, perhaps an increased need for some oxygen, usually we can figure out where the fracture is by direct observation. X-rays really, we don't think are necessary. And at this point, it's some soft wrap, some splinting, and usually a little bit of Tylenol is sufficient to get the babies through this new fracture period. And this is to say, this is really the work of a huge team of people that each had a significant role in taking their element of care and adapting it for osteogenesis imperfecta. And I hope that we continue to move this work forward. This was really important to me. And for those of you wondering, I'll point out this boy in the middle. He's now my almost 12-year-old, who, again, the NICU doctors did amazing things for. So thank you. I see some things in the chat. I'm going to stop sharing and we can answer some questions and discuss. Thank you.